and I'm joined on the call with the rest of the committee members, actually. So welcome to our first ever Zoom study evening. We'll be keen to hear your evaluations and your feedback. We're renowned for our face-to-face study days at the Source in Sheffield, and since COVID we've not been able to do that, but we hope that we'll see you at the Source again in the not too distant future. We've got a really informative agenda this evening and 3 very experienced speakers, so we hope you'll enjoy it. Before we start, a couple of housekeeping requests. Please can you keep your microphones muted so that everybody can hear the speakers. If you do there will be some opportunity at the end of the study evening for questions and comments. So if you do have anything, if you could pop it in the chat and then we'll address them as we go towards the end of the evening. And that hopefully will generate some discussion. At the end of the evening, we've also got a prize draw. So you've got to be in it to win it, and you've got to be here to win it. So you need to stick around till the last minute, really. So without further ado, let's get started. I have great pleasure in introducing our first speaker, who is Hannah Dickinson. So Hannah has 6 years experience in cardiac critical care and community nursing, and studied at Leeds Beckett and completed a critical care master's PG cert in Huddersfield. She's currently she has extensive experience in pulmonary artery catheters, balloon pumps, emergency resternotomies, etc. And Hannah's currently in the progress of moving to America with all of that that entails with personal and professional requirements. So she's going to work on a cardiac intensive care. So I'm sure you'll join with me and wish her all the best for that huge change in career and huge move. So thanks for being here, Hannah, and we wish you every success in the future. So over to you.
Okay, so hi everyone. I hope you can all hear me and see me. So I'm going to be doing a presentation about cardiac arrhythmias, ECGs, and a bit of physiology about the heart and the electrical process. So I'm just going to share my screen and stop my video because I don't want to be on video. So there, I hope you can see that. Okay. So yeah, my name's Hannah. I've been working on cardiac ICU for about 4.5 years. I've been in community for 2 years, and in cardiac ICU we use intra-aortic balloon pumps, PA catheters, pulmonary artery catheters, which we use to conduct cardiac output studies. We use CVVHD, which is filtration, and working on the cardiac intensive care, you have to be trained in resternotomies, which is when a patient's had cardiac surgery. Sometimes they can tamponade, and we need to get into their chest really quickly to relieve the tamponade and get their heart beating again. Okay, so first of all, we're going to talk about the heart and the electrical system. So I like to think about the heart in 2 main components. So we've got the electrical system and we've got the plumbing system. So the heart needs rich oxygenated blood to be able to work properly, which in turn allows the cells of the heart to contract properly and push the blood through the heart and through the body. Both need to be able to work together to efficiently pump the blood through the heart into the lungs and then back through the heart into the body. And the heart works so independently that it is able to continue to beat if you removed it from the body, which is not recommended, for 5 to 10 minutes, thanks to the molecule adenosine triphosphate. Okay, and then the electrical conduction system. So here's the heart. And we're going to start off with the sinoatrial node. And this is one of the main pacemaker cells. Well, the pacemaker cells of the heart are the only cells in the body that can depolarize without requiring the neighbouring cells to do so, and this is called automaticity. They work independently to initiate the contraction of the heart, but the heart rate is also influenced and regulated by the nervous system, hormones, and other factors. So the sinoatrial node is located in the right atrium here, and then it sets the pace of the heart by sending a signal to the neighbouring cells in the left and right atrium through intranodal tracts, which you can see here as little dashed dotted lines. You also have something called the Bachmann's bundle, which is located towards the left atrium. And this also transmits the signal to both atriums so they can contract simultaneously. And then this signal then reaches the atrioventricular node, where there's a slight delay. So you need the delay so the atrium can contract and then the ventricles can fill with blood. If you didn't have this delay, there wouldn't be enough blood in the ventricles for them to then push the blood through the heart. And then that would affect your cardiac output. It would affect your perfusion. So yeah, you need a bit of a delay for it to reach the AV node. And then it travels down the bundle of His. And then it goes to the, I can never say this right, the Purkinje fibers. And when the signal reaches here, it travels really quickly because the ventricles need that signal to be able to contract really hard and get the blood through the heart. And all of that happens within a second, pretty much. Okay. So now, for the heart to be able to beat and for the cells to be able to work, they need like electricity, they need a stimulus. So the cardiac cells produce the electrical stimuli required for the heartbeat through an exchange of ions. So this is called your action potential. So here's a little diagram of your membrane potential. So the cell at its resting state has a negative inner charge compared to its surrounding environment. So the depolarization process starts at around minus 60 millivolts, and this is with potassium inside the cell. And then it starts to spontaneously move upwards due to the opening of voltage gated channels, or they're also known as funny channels, which is pretty funny. And this slowly allows sodium to enter the cell. And then this will make it reach around minus 40 millivolts. And then at this point, calcium channels open, which really speeds up the depolarization process. You can see here. And then after this, it will reach a peak where the cell is at its most positive, and then the potassium channels will open and the potassium will leave the cell, and then this causes a rapid repolarization of the cell. And then it will return to its resting membrane potential, but it will overshoot a little bit and get really negative, and then it will return to its resting membrane potential, and this is known as the refractory period. See there? And this cycle repeats and occurs once every second in a normal, healthy heart. But most of the hearts we work with aren't normal or healthy, so things can affect that. Okay, so I'm going to go and talk about arrhythmias, normal rhythms. We're going to go through all of that, and it's nothing too complicated. And I just want to make it nice and easy for everyone, and stuff that I would have appreciated when I first started as a new nurse. So this is your normal cardiac cycle. So we expect to see a P wave, and then you've got your QRS interval, your QRS complex, and then you've got a PR interval, which you'll hear mentioned a lot. There's a lot of arrhythmias where the PR interval is affected. It's either longer or shorter or non-existent. And then you've got your QT interval, and then there's some drugs and medications that can affect your QT interval. And you might hear of some patients having a long QT interval syndrome. Medications that can affect that is one that we give quite a lot on ICU is ondansetron. That can give you a long QT interval, and that puts you at risk of some arrhythmias that we'll talk about later. And you've got your R to R interval. And then I've just put the timings here, but I'm terrible at remembering these and I always need to Google them if I'm doing a 12-lead ECG to figure them out. Okay, so we're going to go to sinus rhythms and arrhythmias. So here is, you've got a normal sinus rhythm, which is around 60 to 100 beats a minute. And then we've got sinus bradycardia, which is less than 60 beats a minute. This, you will find some patients, if they're quite young, quite athletic, they might normally be bradycardic, or if your patient is on some beta blockers, they might also be bradycardic. If it's quite a slow rate, you might want to see if the medication needs reviewing. They might be on the dose might be too high. Sometimes when your patient is asleep at night, it might drop a little bit low, but you wouldn't expect it to be lower than 50 really. And then you've got sinus tachycardia, which is a fast heart rate. It's above 100 beats a minute, but you've still got your P waves. But you can see in this example, your P wave is buried in the T wave. So it gives it a little bit of a humpback appearance, but your P wave is there. So you know it's sinus. And then one that not many people know about is sinus arrhythmia, which is you're getting the normal PQRST rate, but then it's not quite regular. It looks a bit irregular. So you've got 3 together at the front there, and then it extends out a little bit. And when I was a new nurse, I used to think that was AF because it was an irregular rhythm, but it's a normal PQRS. It's just a little bit irregular. And this is benign. It's a normal occurrence in young people. And it usually happens due to changes in pressure during inspiration and expiration. So yeah, sinus arrhythmia, if you've got P wave, QRST, it's just a little bit irregular, it's nothing to worry about. Okay. And next up we have arrhythmias of atrial origin. So these are still occurring in the atria. They just might not necessarily be coming, the impulse might not be coming from their SA node. So we've got atrial tachycardia, and this one is sometimes really difficult to distinguish from sinus tachycardia. You've still got a P wave, but again, it's buried in the T wave, so it's a bit hard to see. It's a lot less common than sinus tachycardia. So if in doubt, just document sinus tachycardia and then just try and get a 12-lead ECG and then just get some medical, maybe a doctor to come and have a look and see what they think. And again, it'll be above 100 beats per minute. And then next we've got a wandering atrial pacemaker, which it took me a long time to realize it's nothing to do with a pacemaker, like a permanent pacemaker or an external pacemaker. It means the pacemaker of the heart. So it's a benign rhythm. You've got P waves that are present, but you can see here that there's a tall P wave, a short P wave, there's 2 little P waves together. And it just means that the impulse is occurring at different atrial sites, but it's still following the same pathway and giving you the QRS. And sometimes this is caused by patients with lung diseases such as COPD. It might be electrolyte imbalances or stimulant use, but you're still going to get your QRS. And then we have atrial flutter, which I'm sure a lot of you might have seen. It's really distinct. It's got what we call a sawtooth pattern. And what this is, these are called flutter waves. So you get 250 to 350 flutter waves per minute, which is a lot. And it's an abnormal conduction pathway. So the atria is firing multiple times. So it's sending out loads and loads and loads of impulses all around. However, due to the refractory period that I talked about previously in the action potential, the ion gated channels are closed. So the AV node, it's not going to pick up all of these impulses, because if it did, you'd have a heart rate of 250 beats per minute. And I don't even think that's compatible with life. So the AV node, it's not going to follow through on every single impulse that's sent out. It's only going to pick up every so often. So you're going to get a regular QRS, but you're going to get this sawtooth appearance from the flutter waves. This can be caused by ischemia, hypertension, cardiomyopathy, or heart surgery. And if you see this if you're working on a ward, if you see this on your ECG, I would just go and grab your 12-lead ECG and get a printout and get the doctor to have a look at it and just make sure your patient is feeling okay. And then we have the classic AF. We see this all the time on the cardiac intensive care. It can be slow AF. Sometimes we get patients who have chronic AF. A lot of patients after the cardiac surgery suddenly go into fast AF and they'll start to feel lightheaded, a bit sweaty, sometimes they feel really nauseous. And it's a chaotic and disorganized rhythm, so you can't really see any P waves. And the way I learned it, which I found really helpful, if you're staring at your monitor and you're trying to convince yourself that you're seeing P waves, like you think, is it a P wave? I'm not sure. If you're getting the nurse next to you to come and have a look to see if they think it's a P wave, you're probably looking at AF, because they'll be really fine, really chaotic. And the thing with AF is, because the atria are fibrillating, they're not properly ejecting the blood into the ventricles. So if you're not clearing the blood out of your atria with each beat, you're going to get some blood kind of hanging around in the atria. It's going to be clotting, and then you're at risk of those clots firing off into like your lungs or traveling up into your brain. So patients in chronic AF, they need to be on some anticoagulation. We usually find that they're on apixaban or rivaroxaban. If you're in the ICU or on a ward and they're going to fast AF, then we usually treat it with amiodarone, some fluids, some bisoprolol to try and like control the heart rate, and usually a bit of fluid as well. And some patients in cardiac ICU will be on a dopamine infusion. So if you can, try and turn it down a little bit, because that can cause AF sometimes as well. Next, so we have arrhythmias of a ventricular origin, which is my favorite, but probably not your patient's favorite. I find the most interesting. So here's just a few examples, but we'll go through some of them now. So PVCs, so I see these all the time on the intensive care unit, on your monitor. They come from a singular irritable site in the ventricles, and the impulse is early, hence why we call it premature ventricular contractions. I always describe them as early, wide, and ugly. They will really stand out on your monitor. They don't conduct through the normal cardiac fast track cells, so they don't go through the SA node, they don't go through the AV node. They come from an irritable site in the ventricles, and this will send out an impulse, and it will travel through the cardiac, contractile, and conductive tissues to activate the lower chambers. And it can do this even though it's not following the SA-AV node pathway. It can do this because of the gap junctions in between the cells. So these connect all the cells together. And it is possible, but it will just result in a slower conduction, hence why it looks quite wide and ugly, because it's just slower conduction. One PVC every so often is harmless. Usually it indicates some electrolyte imbalances or some stimulant use. So if you had a lot of coffee that day, you might feel like, sometimes I feel like I get one every so often when I've had a lot of coffee. But if you're getting quite a lot quite often, it can be that you've got some coronary perfusion issues. And it's really common to see them after a patient has come in with a STEMI. So when I get a patient admitted to us who's been up in the cath labs, so they've had a heart attack, they've gone to have a stent put in, they come back to the ICU, they usually throw off quite a lot of PVCs because the heart is trying to reperfuse, and it's just not quite getting the right cardiac, like the conduction pathways. It's trying to like reperfuse and get them back to normal. So they'll tend to throw off some PVCs, and the heart's been irritated as well by the heart attack. So yeah, so initiated elsewhere in the ventricles. There you go. And then sometimes you get unifocal PVCs, so ones that will look the same. Sometimes you'll get multifocal, so they'll still be wide, complex, but they might be taller or shorter. They might just look slightly different. And then these are all PVCs, but we've got different names for them. So this is a couplet. So it's 2 together before normal sinus rhythm resumes. And then you have something called bigeminy, which is a PVC every other sinus rhythm beat. And then we have trigeminy. So every second beat, you'll have a PVC. And then quadgeminy, after every third beat, you'll have a PVC. Yeah. So next we've gone to non-sustained VT. So this is what it might look like. So this is 3 PVCs in a row. Non-sustained VT is usually classified as 3 or more PVCs, but it doesn't last more than 30 seconds. If it's lasting more than 30 seconds, you need to start getting your defib near you, getting some help. But yeah, sometimes on the ICU, my monitor will alarm saying there's non-sustained VT. But by the time I've gone over to my patient, it's resolved and the patient's back in normal sinus rhythm. All it means is that there is some underlying thing going on. It might be ischemic changes. Yeah, but usually from my experience on cardiac ICU, patients come to us with an external pacemaker fitted. And usually it's something to do with the pacing interfering with the normal electrical function of the heart, like they're kind of fighting against each other. So if you're in that situation on a cardiac ICU, just get one of the surgical registrars to come and have a look, or one of the very skilled ACCPs, Sharon. So yeah, if you see this, if it keeps happening, assess your patient, take some bloods, complete a 12-lead ECG, and then get a medical review of your patient. And then we're going to go into the really nasty ones. So we've got VT. So this is described as a potential lethal arrhythmia, but I would definitely classify this as a lethal arrhythmia. So this is what it looks like. It's really wide, really ugly, very fast. So you've got a wide QRS, but it's got a regular R to R interval. There's no P waves, so you can't see any P waves there. And you may produce a pulse. I've seen quite a number of patients who have been sat up in bed in VT, and they've got an arterial line in so we can monitor the blood pressure, and they've got a good blood pressure. They're able to talk to you. They don't feel too unwell, but then they do usually quickly become more and more drowsy. The blood pressure drops, and that's because the ventricles are impaired, so they're not filling as well as they should, and they're not ejecting blood as well as they should. So then your cardiac output is decreasing, and that's going to give poor perfusion, and then they're going to start feeling really lightheaded as the brain isn't getting enough blood and oxygen to it. So there's a number of ways to treat this. If you see VT, you can't feel a pulse, you can't get a blood pressure, you need to start CPR and get them shocked. If your patient is awake, you need to, I'd definitely put the defib pads on them, keep checking for a pulse, get some help, and then you can give them drugs such as amiodarone. You might want to give them some midazolam or some sort of sedative so you can perform a synchronized cardioversion. But for all of this, like, get some help. Yeah, and the quicker you sort it, the less at risk of any brain damage they are. And then I find this one so interesting. So this is called torsade de pointe, and it's French. I hope I didn't say that too wrong. So this is a form of VT, but we call it polymorphic VT. And the French means twisting of the points. So you've got multiple ectopic sites, and so the ventricles there's lots of ectopics going on in the ventricles, and they're coming from different axes around the heart. So some are coming towards the ECG lead, some are going away from the ECG lead, which is why you're getting positive and negative. So you're getting an up and down, like ECG look on your screen. It's really fast, so it occurs around 250 beats per minute. So it's got a lot of positive and negative deflections, and it gives it, it's called a bow tie. A lot of people describe it as a bow tie, the appearance of it. And presentation of this really does depend on the patient. So the first time I ever saw this as a newly qualified nurse on intensive care, I thought this was VF. I thought the patient was in a really lethal heart rhythm. I thought the patient had died, and I was about to start CPR, but my patient was sat upright in bed looking at me. So that confused me. And so sometimes your patient will have a good blood pressure with this rhythm, and it's usually caused by low magnesium levels or a prolonged QT interval, which is, I mentioned earlier, so that can be caused by some drugs like ondansetron. So if you see this rhythm and you've still got a blood pressure, your patient isn't feeling too unwell, I would get the defib near the bedside, get a 12-lead ECG, get some medical review, because they're probably just going to need an infusion of magnesium and maybe some other medications to help. And it's also really common in pregnant women as well. But I don't look after many pregnant women, so I've never seen it in a pregnant woman. Yeah. But it'll be different for every patient. So some patients might be very unwell with this, so it needs treating quickly. And then you have VF, which I'm sure a lot of people will know. And this is the one that makes you sweat a little bit. So this one occurs due to poor cardiac perfusion. So it could be trauma, blood loss, a tamponade, electrolyte disturbances, deterioration of other lethal arrhythmias. So your patient might have been in VT and now it's deteriorated into VF, or your patient might have become hyperkalemic. So if you've got really high potassium, your action potential of the heart is affected, and then it can't produce a proper electrical stimulus, and then you're going to eventually go into VF with that. So you need to respond to this one really quickly. So this one needs CPR immediately. You need to shock them as soon as you can. If anyone has ever worked on a cardiac ICU, we do it a bit differently. So if our patient goes into VF, we give them 3 stacked shocks. And then if that hasn't brought them back, if that hasn't got a sinus rhythm, then if they've had cardiac surgery recently within the last 10 days, we need to get into their chest, because it's most likely that they're tamponading. So they're bleeding from the heart into the surrounding area of the heart, which is compressing the heart. So the heart actually can't beat because it's been compressed by its own blood. So we need to open their chest really quickly and get all that blood out so it can beat again. But that's only for cardiac ICU. And then we have asystole. So this is, there's no electrical activity in the heart. You can't shock this because there's nothing to shock. There's no electrical activity to restart. So you start CPR, and then you just need to administer drugs according to your local advanced cardiac life support guidelines. For the United Kingdom, we use the Resus Council guidelines. Yeah, and then you need to try for all of these rhythms, any arrhythmia, you need to try and identify some reversible causes. So I'm just going to quickly go through those and then we're done. So we've got the H's and the T's. So anytime your patient arrests, what could have caused this and what can we do to fix it? So they might be hypovolemic, especially after surgery or trauma. They might be hypoxic. So is it a respiratory issue? Acidosis could also be because of hypovolemia. They might have hypo or hyperkalemia, or they might be hypothermic. So I had a patient the other day who was very bradycardic, about 35 beats a minute, and it's because their temperature was 30, I think it was about 34.9. So they needed warming up, and they were also very hypovolemic. So we gave them some fluids, we warmed them up with a bear hugger blanket, and then the heart rate increased back to about 65. It's good. And then you've also got tension pneumothorax, tamponade, which I've also mentioned, toxins, and thrombosis. And these are all potential reversible causes in an arrest situation. Yeah. So thank you for listening. I hope that was all right. I've just put my references on there, and then what I find really useful, if anyone's got Instagram, these 2 links at the bottom. Each day, the visual nurse, he puts up ECG rhythms, like a little quiz for you to practice, which is found really handy. Yeah. So thank you, everyone. I'll stop sharing.
Thanks very much, Hannah. There was a message in the chat box. Will we be able to have access to the slides? Would you be happy for us to share the slides on the website?
Yeah, of course.
Thank you very much. So let's move on. There will be an opportunity to ask Hannah some questions later on. So next speaker is Christopher Hyde-White. Now, we asked Christopher to tell us a little bit about himself so I could introduce him. What he said was, after a brief detour to head and neck surgery, he's worked within ICU for 21 years, first in York, then Dubai, and then now in sunny Scunthorpe, becoming a clinical nurse educator in Scunthorpe ICU in 2018. Christopher's one of our regular speakers, and if you've been to the source to attend any of our study days, you will have seen him before. He also told us he's got a wife, 5 chickens, and a mortgage that refuses to go away. Over to you, Christopher.
Hello, everybody. Right, I'm sharing screen now. Okay, can everybody see that okay? Yeah, fantastic. Well, good evening, everybody. There's more and more of you out there. As my introduction stated, I'm here to talk to you a little bit about cardiac output monitoring, but very much with my nurse educator's hat on. Not by judgment, just by accident. Every ICU I've ever worked in has been a general ICU rather than having any speciality, and particularly not any cardiac speciality. So we've always kind of come at our cardiac patients from the outside, if you like. Once they get too complicated or need anything too in-depth, we generally send them to a specialist center. So cardiac output monitoring, I kind of view as us dipping our toe into the world of cardiology. And from a nurse educator perspective, I think it's kind of my job to engender nurse engagement with cardiac monitoring, because it's increasingly important, and more the nursing staff are the people who are initiating cardiac output monitoring, particularly now we've got non-invasive cardiac monitoring. And they're the people who more and more are going to be reacting to the observations obtained from those cardiac output monitors. So with this in mind, I see my role as an educator to not only increase the knowledge of the area and the understanding of what it means, but also, if possible, to make cardiac output monitoring interesting and God forbid, even exciting, because it's one of those subjects. I remember well my first introduction to the subject of cardiac output, and I found it absolutely bewildering. And when something is absolutely bewildering, especially to the adult learner, as I was at the time, you tend to switch off a little bit from it. So the more engagement we can get and the more exciting we can make it, the better it is, I think. So very much from a cardiac output perspective, the question I'm trying to answer, the unspoken question in all nurses' minds, is cardiac output, why am I even bothered? So here's a choice blood gas we took from our unit last month. I didn't have to search very hard for it. And aside from everything else unusual on it, what you can see there is an elevated lactate of 3.4. Now, all we really know, looking at that elevated lactate, is somewhere in that patient's body, there are some cells that are not getting enough oxygen. And this is a symptom of poor perfusion. And the cause has lots and lots of places to hide. So we know somewhere cells are not getting enough oxygen, but without cardiac output monitoring, that cause can still remain hidden and appropriate treatment not be started, because your initial reaction might be, let's throw some more oxygen at it. But we can see from that patient's blood gas, they're not lacking for oxygen in their blood. They have plenty of oxygen there. So why isn't it getting to the cells that need it? And cardiac output monitoring provides the evidence in kind of a whodunit, which is, why is my patient so poorly perfused? So when I'm starting to teach new staff nurses cardiac output monitoring, I try and think of a real world situation where it might be important to look at a lot of evidence to try and solve a problem. So here we have a problem. We have a prone human body lying in the middle of a traffic junction. We arrive at the scene from the street on the right, and as we're all registered staff nurses, we're obliged to at least try CPR, but it very quickly becomes apparent that this victim, while still warm, has very definitely gone to a better place. Something terrible has obviously happened here, and we have to investigate. So let's question the cyclist over on the left of your screen. Now, on questioning the cyclist about what he's seen, he said he has ridden for some considerable time along that road to the left. It's a long, straight road, and he was passed by absolutely no cars. In fact, so little traffic that he suspects that road might be closed. He certainly as well didn't pass our victim. In fact, the first time he'd seen this body was when I pointed it out to him at the junction. So really not a lot of information, not a lot to go on there, but some information. We know it's very unlikely that she was hit by a car approaching from the left. Next, let's turn to the traffic camera over on the right of the screen. Now, unfortunately, Sod's law, that traffic camera is pointing away from the junction. But it does show that there's been no traffic approaching from that direction for the last 40 minutes. And certainly there's no sign of our victim approaching. So we've got some more pieces in the puzzle here. We're ruling out some of the reasons why this victim might be on the road. Now, we've called the emergency services by now. Some time has passed. The police have been and examined the body, and they've very kindly given us access to the scene of crime report. So on examining the body, they find that our poor victim has a traumatic injury to the rear of her head. She has swelling around her mouth and her face. And she also has petechial hemorrhaging in her eyes, which, as all of you good people who watch Midsummer Murders regularly will know, indicates hypoxia. But importantly, she doesn't have any injuries anywhere else. So we're starting to get a picture of the fact, was this person hit by a car? It doesn't seem like it. We haven't got any traffic approaching from the road on our left or right. The road we walked up to from the victim approaching from the right didn't have any traffic on it. So was she hit by a car? So far, the evidence points away from our victim having been hit by a car. The cyclist saw no traffic, the traffic camera shows no vehicles approaching, and neither we nor anybody else saw her approaching the scene from any of the routes on the left or the right of the screen. This leaves the street opposite. So let's have a closer look down this street and see if we can find any evidence to point to what's happened. On closer inspection, we find a discarded handbag. And looking inside the handbag, we see from the driver's license that yes, it does in fact belong to the lady. We also see that she pretty much looked the same in life as she did in death. Also in that handbag is an unused EpiPen. So we're starting to form a picture of a person who maybe suffers from quite severe allergies if she's careful enough to carry those around. Now, very mysteriously, scattered all around the scene where this handbag is, are open shell peanuts, and more peanuts are appearing from above the longer we stand there. So we're starting to form a picture now of a patient who had a victim who had a severe allergy to peanuts, and maybe anaphylaxis is the cause of this. But the mystery now is, somebody knew they had an allergy to peanuts. Why were they carrying peanuts? And more importantly, where were these peanuts coming from above? Now, as we look up, the last place we haven't looked, we see that there is, of course, an escaped monkey on top of the building. So it seems poor Lacey was hit by falling peanuts thrown from above by an escaped monkey. Before she realized what was happening, her allergy was triggered and she staggered into the junction, only to collapse backwards, cursing all monkeys and all of their kind. Which brings us nicely back to our elevated lactate. Now here we have a problem, but unless we can find the reason for that problem, this situation is slightly different. There's no hope for Lacey anymore, but we could reverse this problem. We could save this patient from this elevated lactate as long as we can find out what the problem is. So this gives us a kind of diagnostic tree at this point. And with cardiac output monitoring, we'd have all the information we needed with the addition of a couple of other things to try and find out where this problem lies. So first of all, we could look at our blood gas and say, is the patient anemic? This could well be a reason why they're not able to deliver oxygen to these cells that are producing this lactic acid. We can see on the blood gas that no, they're not anemic. They've got a perfectly healthy hemoglobin of 132. So we've ruled out that problem. Next, we'd have a look and say, is the patient hypoxic? Well, we already had a look at the gas earlier and we can see they're fairly well saturated and their PO2 is excellent. So that's not the issue. Now, the last remaining place this problem could be hiding is a problem with cardiac output itself. Now, cardiac output has 4 determinants. First on that list would be heart rate. So presumably this is an ICU patient. It would be very remiss of us if we weren't monitoring their heart rate. So are they profoundly bradycardic? Now, unless this happens to be an Olympic athlete we're working on here, bradycardic heart rates are not going to be able to make up for that cardiac output by enormous muscular stroke volumes. Most of our patients do not have enormous muscular hearts. So if our patient's bradycardic, that could be what's affecting their cardiac output. The next determinant would be preload. How much fluid are we managing to get into that all-important left ventricle before it squeezes and pushes that load out into the aorta? Next on that list would be contractility. Is the pump itself working? So there's no good filling a broken pump up with fluid only for it to pump only half of that fluid out into the aorta. So that could be the problem. And then lastly, the afterload. What resistance is that left ventricle trying to empty itself against? Too much resistance and you won't get complete emptying. Too little resistance, your heart will think it's Christmas Day. It will pump liters and liters of blood out into your circulatory system. But without that resistance, it won't be able to make blood pressure. So it won't be able to deliver that oxygen around to the rest of the cells. So this is the point at which we would slap on our cardiac output monitor, and slap on accurately describes how we do it now, because with our non-invasive cardiac output monitors, it literally takes 2 minutes to get this on. And that was previously, I think, a huge obstacle to starting this type of monitoring, was the fact that it was so long and laborious when we used to calibrate our cardiac output monitors with lithium. Now all we need is an arterial line and some leads. Plug a few figures into the machine and it will give us our cardiac output value. So you can literally get the process started within 5 minutes. So with our cardiac output monitor in place, we can now get some answers to those questions. What specifically is it about cardiac output that is compromised? So the first thing we would always check would be the preload. Are we getting enough fluid into that heart for it to pump forward effectively? So by looking at the stroke volume variation, so how much the stroke volume changes as the respiratory pattern goes in and out and the interthoracic pressure goes up and down, will give us an indication of whether this patient would respond well to fluid. Now, if that change is 10% or above, we would say, okay, there's every likelihood that this patient would respond well to having fluid. And anyway, we need to give them that fluid to get it below that 10%, because then we can rule out preload as being the problem itself. So if we found no problem there, or we found that we did have a preload problem and we've now got some fluid on board and made it go away, and we've still got our elevated lactate, next we would look at afterload. So our cardiac output monitor is going to give us a figure for our systemic vascular resistance. So how much resistance is that left ventricle facing when it tries to pump blood out into the rest of the circulation? And this is very much like Goldilocks and her porridge. It doesn't want too little, it doesn't want too much, it wants it to be just right. If we have too much resistance to that left ventricle, it won't be able to empty effectively. And if we have too little resistance to that left ventricular output, then yes, you're going to get lots and lots of blood being pumped out into the aorta, but you're not going to make blood pressure from that output. And that's the all-important figure in delivering that oxygenated blood round to the rest of the body. So again, we may have found that there was no problem there, or most commonly you'll find in problems with cardiac output, there's low systemic vascular resistance, which we could potentially treat with a positive vasopressor, such as noradrenaline. Bring that up to normal and see if the problem has gone away. Now, if the problem hasn't gone away, with a normal systemic vascular resistance and a good-looking preload, there's one last place it could be hiding, and that's in contractility. So this isn't something that your cardiac output monitor is going to be able to tell you, and it shows the importance of having on these patients, particularly a recent cardiac echo, because that's going to give you pretty much all the information you need as to whether that pump is working effectively and pushing that blood forward. So effectively, what we're doing here is going down a tick list of the causes of hypoxemia to see why we've got this elevated lactate. So with our blood gas, we can look at the PO2 and the saturations and rule out or rule in hypoxic hypoxemia. If that was a problem, fix it. Get oxygen into this patient's blood via ventilation. If we can fix that problem and we still have our elevated lactate, that's not where the problem was. At least we know that's not where it was hiding. Next, again, on our blood gas, we can check the patient's hemoglobin and potentially rule out anemic hypoxemia, which we can see on this blood gas. Of course, that's not an issue for this problem. But again, if it was, correct that and see if that fixes the issue. Then with our cardiac output monitor and our recent cardiac echo, then we can rule out stagnant hypoxemia. So is the issue that we don't have enough preload, we're hypovolemic, we're underfilled? Is the problem that we don't have a systemic vascular resistance? Or is the problem in the heart itself? And if the cardiac echo shows that it is a problem in the heart itself, is that something that can actually be fixed? Or should we be continuing to treat this patient? Now, if we rule out problems in all of those areas and fix all of those problems, that only really leaves one area left, which is toxic hypoxemia. So two causes sometimes put under toxic hypoxemia would be, for instance, carbon monoxide poisoning. Now, that's something we can see on the blood gas, and with a COHB of 1.9, this patient's not suffering from this. We could maybe sniff their breath and see if they smell of almonds, see if their nearest and dearest has given them cyanide in their last meal. That could be another potential cause of toxic hypoxemia. But I think it's easy to see that without that cardiac monitor in place, you're treating blind in effect. You could say, okay, we'll give this patient some fluid, but you don't know if they need that fluid to reperfuse themselves properly or whether they have a problem with resistance. And again, I would say the same about the recent cardiac echo. If you go ahead and treat blindly without knowing if that pump is working effectively, you can end up doing more damage than good. So, excuse me. I would say that similar to our investigations into the poor deceased Lacey Tate, without cardiac output monitoring, we may well be unaware of the root cause of the problem, assuming she was run over and ignoring the monkey on the roof. Anybody have any questions? I guess they're all going to the chat room, aren't they? Yeah, okay then. Right, thank you very much indeed.
Thank you, Chris and Christopher. Sorry, I'm calling you Chris. Do you prefer to be Chris or Christopher?
Christopher, if you have time, but I'm not going to pick you up on it.
Okay, I'll remember, Christopher. Thank you very much for that. I was wondering where the thing with the lady in the road and the monkey were going, but actually it all came together in the end. So it was really quite, yeah, quite interesting. I'm sure there'll be some questions in the chat later on. So thank you for that. So moving swiftly on to our last, but certainly not least speaker. So Dr. Andy Haynes. So Andy is a registrar in ICU and ED. He's got a keen and active interest in human factors training, and actually spends some of his spare time in pre-hospital care and event medicine. So busy bee. So over to you, Andy, who's going to talk about inotropes.
Thanks, Di. Yeah, I'm not gonna, it's not really any more introduction than Di's already done. So I'm just going to put some slides up, of which I have very few. Can somebody wave and confirm those are working correctly? Yeah, excellent. So we're going to spend just hopefully the last 20 minutes talking about inotropes. This I always think is one of those topics where people can get very confused very quickly, because this can be made extremely complicated without any difficulty whatsoever. And I think we've probably all been in the situation of a ward round happening, or cardiology consultant coming onto the unit and giving some advice about inotropes, and then they walk away and you think, why on earth are they asking us to do that? And I don't profess that this way of thinking about inotropes is like the way. It's just a way that I find easy when it's 3 o'clock in the morning and I'm trying to work out what to do with the patient, or someone's telling me to do something and I don't really understand why they're asking. I find it just an easy way to work through inotropes. So there is some evidence in this presentation, but not much, to be honest. So the first thing I'm going to do, if this works, is just put these equations, or this equation, rearranged up for everybody to look at for 10 seconds and remember from whenever you last saw it. This is going to become important, well, in the next slide. Obviously, we're all familiar with blood pressure equals cardiac output times systemic vascular resistance. I'm hoping that is not news to anybody. The other way of rewriting that equation is that cardiac output is blood pressure divided by systemic vascular resistance. And that is going to be important in a minute, because what that is essentially telling you is that if you increase a patient's systemic vascular resistance and their blood pressure doesn't change, their cardiac output has gone down. And if you think about it, most of the organs in your body care much more about cardiac output than they care about blood pressure. Some of them need particular blood pressures to get blood to them. But once that blood pressure is reached, having more blood pressure is not beneficial. But having more blood flow and more oxygen delivery and more glucose delivery and more removal of carbon dioxide is beneficial. So once you have an acceptable blood pressure where your kind of kidneys and your brain and your heart have turned pink, from that point on, we're really interested in cardiac output, but we don't often measure it. Obviously, previous presentation notwithstanding, we spend a lot of time looking at blood pressure as a sort of marker of cardiac output, which it's not. Anyway, so we just have that in the back of your mind as we look at the inotropes. We're going to talk super briefly about some physiology. And I apologize if this is stuff that people know intimately and have written about in your step 3 modules or whatever. But just so we're all on the same page, we're just going to go through what these inotropes sort of do on a physiology level before we talk about how we kind of use them practically. And essentially, most of the inotropes we use, or most of the positive vasoactive medications that we use to increase people's cardiac output or blood pressure, work on the sympathetic nervous system. And they hit one of these 2 receptors. So they're alpha or beta, or in some cases, both. There are groups of these, and these are essentially the receptors that are out there. Some of these we care about clinically, and some of these we don't. So we can sort of simplify this in a minute down to the bits that we actually think about when we're choosing an inotrope. Basically, at the level you're kind of interested in at 2 o'clock in the morning on ITU, the alpha receptors are peripheral and the beta receptors are central. And if you have that sort of broad idea in your head, that gets you 85% of what you need to know about choosing an inotrope, unless you're doing cardiac surgery or something very specific. So things that hit the alpha receptors do the peripheral actions, things that hit the beta receptors do the central actions in the heart and the lungs. And some of these things you kind of can remember based on common drugs that you're familiar with. You know, salbutamol, it's a beta 2 agonist, it blocks beta 2, stimulates beta 2 receptors. So you can think, what does salbutamol do? We all know what salbutamol does. It relaxes your airways. So that's what beta 2 receptor does. But this is the two sort of broad camps that we want to split these inotropes into as our first distinction. Are they primarily alpha, or are they primarily beta, or are they both? These receptors do some specific things, and some of these we don't care about very much. Alpha, most of the alpha effects that we see in clinical practice when we give an inotrope or some kind of vasoactive medication that stimulates alpha receptors are because of alpha-1 effects. So they are smooth muscle constriction effects in the periphery. So in blood vessels, in your arms, legs, muscles, bowel, wherever. Alpha-2 is an odd receptor because it's like a feedback loop. So as you give these drugs, if they start to have alpha-2 effects, or if you have, you know, your own adrenaline going around, when they have alpha-2 effects, that's sort of like a negative feedback that damps down the alpha-1 effects. We don't care about that in clinical practice, really. So when you're thinking about choosing an inotrope, if it's an alpha acting inotrope, it's a smooth muscle constrictor that acts in the periphery. That's when you broadly talk about alpha agonists, that's what they do. Beta is a little bit more complicated because there's two of these that are clinically significant. That's beta 1 and beta 2. Beta 3 is a receptor that basically breaks down fat and turns it into glucose, and to some degree drives lactate. And it's that beta 3 effect that's why if you've had 3,000 nebules of salbutamol, your lactate will be 35. But we don't care about that in clinical practice. It doesn't really affect your blood pressure, and you can ignore that lactate because it'll go away once you stop giving the salbutamol. Beta 1 and beta 2 are the ones we care about, and beta 1 is what we care about as a vasopressor. That is the receptors primarily in the heart that increase heart rate, and they also increase contractility. So how hard the ventricles and the atria to some degree contract with each stroke. The beta 2 effects is essentially what you think of salbutamol doing. So it's a smooth muscle relaxer, primarily in the central core areas. So it relaxes smooth muscle in your airways and opens your airways up. That's why we use it as a nebulizer. It relaxes smooth muscle in other organs in your core body. So it can be used to stop labor contractions by relaxing uterine smooth muscle, for example. So that's what beta 2 does. The beta receptors are quite similar, and so there are not very many drugs that are very highly selective for one or the other. And you all know that because if you give enough salbutamol to someone by nebules, they get tachycardic. It's supposed to hit their beta 2 receptor, but some of it kind of leaks and hits the other one. The same thing happens if you give enough dobutamine or isoprenaline, which is designed to hit beta 1. It kind of leaks over and it hits beta 2 as well. So you always get a bit of both with most beta-acting drugs. What's worth noting is beta blockers are much more selective if you use a new one. And in completely tangentially, I'm just going to mention bisoprolol does not bind on beta 2 to any clinically significant degree unless you give absolutely tons of it. So next time someone tells you that you can't give 2.5 of bisoprolol to your patient because they're on NORAD, they haven't read any physiology. But in normal doses, the drugs we give that stimulate those receptors do hit both. So that's the targets that we can have for our drugs to try and, manipulate a patient's blood pressure upwards or their cardiac output upwards. Obviously, other drugs can manipulate it downwards. It's not what we're talking about. So That's the distinction. How do we then actually, how do the drugs that we use in clinical practice map onto this framework of alpha or beta, beta 1, beta 2? There are two other drugs that don't map on this framework, just worth mentioning in passing that some of the units may use. One is levosimendan and one is milrinone, and they're kind of outside the normal classification of all the other inotropes and vasoactive drugs that we've used previously. So levosimendan is a calcium sensitizer. So what it does is it essentially just increases the cell's ability to handle calcium and to do things with that calcium on a simplistic level. And so what it does is it increases contractility and heart rate centrally, but it does vasodilate. So in that way, it kind of acts like a beta adrenergic drug like dobutamine, only via a different mechanism. And that's the way to think of levosimendan. It's just a different version of that. Milrinone is weird. What milrinone does is it inhibits this enzyme, phosphodiesterase 3. And phosphodiesterase 3 breaks down cyclic AMP. And cyclic AMP is an energy source. So if you stop that being broken down, then cells that use it have more energy and can do more stuff. And primarily where this is significant is in smooth muscle. Now, what's strange is that it has a vasodilator effect centrally and ionotropy, but possibly some peripheral vasoconstriction. It's an extremely odd drug, and I don't really think we know exactly how it works or what it does on the level that we understand the others, that have been around for 30, 40 years. The place that you'll see milrinone used a lot is with people with pulmonary hypertension. So when the pressure in the right side of the circulation in the lungs is high, because it's very good at vasodilating the blood vessels in the lungs, and thereby allowing the heart to pump against less resistance and maybe do less work. So you will see it used for right heart failure, pulmonary hypertension. We used it quite a lot in COVID. So those two are weird and kind of don't fit in the structure very much, but we don't use them very much. We'll come back to them later. Our traditional vasopressors can essentially, and this graphic, if anybody wants these, are all clipped from the Life in the Fast Lane Critical Care Compendium website, which I can put a link in the chat to at the end. You can essentially think about most of the vasopressors we use as being in that grid. So some of them will have vasoconstriction. So those are going to be the alpha ones. Some of them will have inotropy and chronotropy, so they will increase heart rate, they will increase heart contractility. And some of them will also have that beta 2 effect where they bronchodilate you and maybe vasodilate you a little bit if you give enough. And they'll do this to varying degrees. So you can see common things up there. Adrenaline's quite a dirty drug. It hits all the receptors, kind of not equally, but it hits pretty much all the receptors. That's why I use it in cardiac arrest, because it just fixes all problems, apparently. So it does some vasoconstriction. It does some increased contractility in the heart. It definitely increases your heart rate. And it does some bronchodilation in the airways, which, you can see it used in life-threatening asthma and things like that with good effect. Noradrenaline, which we're all familiar with, that's quite a broad drug as well. It's mostly alpha, so it does a lot of peripheral vasoconstriction. It does a little bit of beta as well, so it does a little bit for the heart, a little bit of extra contractility, and as we've probably all seen, if you give enough, it'll make you a bit tachycardic as well, but you have to give quite a lot for that effect to come in. So this 1+ on the right is in the adrenaline, and the noradrenaline column is kind of quite a weak effect. The one that's quite weird on there is phenylephrine, which we don't really use that much, but metaraminol, which I think probably most people are familiar with using a lot. And metaraminol is actually a really clean drug. It's only alpha, and it's probably the cleanest vasopressor that we have. It only vasoconstricts. It doesn't do anything for your heart at all to any degree. the thing about metaraminol is that makes it really useful sometimes and a really silly idea other times. So when you've just intubated your patient with a load of propofol and the blood pressure drops, but actually the blood pressure was totally fine before you put the propofol on, metaraminol's great. You know what the problem is. You've just given them some drugs that vasodilate them. So if you reverse that, great. For your generally septic patient whose capillaries are a bit leaky, who's probably a bit dry, whose myocardium's a bit unhappy, whose coronaries aren't greatly perfused, and then you come along and give them some metaraminol, you can make their blood pressure look excellent, but their cardiac output is probably not being helped by that, because all you're doing is making them pump against a bigger and bigger resistance. So sometimes metaraminol is really useful, but we've probably all seen patients that you can give absolutely industrial doses of metaraminol to and nothing happens. And in fact, sometimes they get worse. And often the reason they get worse is you're doing something very imbalanced. You're doing lots of peripheral vasoconstriction and nothing for their cardiac output. So you're doing exactly what those equations in the first slide said you could do. You're just making the blood pressure look really high, but the cardiac output is actually dropping as you do that. And phenylephrine is very similar. It's just a different form. Ephedrine, now this slide suggests ephedrine only does inotropy and chronotropy. It does do a little bit of vasoconstriction as well, but we kind of don't use that much on ITU. In anesthesia practice, it's used a fair bit, but probably not so much on ITU. Dopamine, I'm kind of hoping no one's using that much dopamine anymore, but essentially the way to think about dopamine is it's just a bad version of NORAD. And anytime you're putting dopamine up, you probably, if you're reading the evidence, would probably be using NORAD. Dobutamine and isoprenaline you can broadly think of as the same drug. They're both beta, so they both are acting centrally. They increase contractility, they increase heart rate. Probably isoprenaline does rate a little bit more than dobutamine, but drops your systemic resistance a little bit more than dobutamine, because dobutamine has a little bit of peripheral action to vasoconstrict you, but not very much. And to be honest, if you just flipped a coin and chose one or the other, you'd probably be okay. That grid tells you what each of those drugs do, but I don't find that very useful at 3 o'clock in the morning to try and choose a vasopressor when I'm trying to work out what to start the patient on, or when someone's giving me complicated instructions. This I find a little bit better. So this basically puts all the vasopressors on a grid, same website, by the way, vasopressors on a grid, and sort of says, what do they do to the peripheral vascular resistance? Do they increase it or decrease it? And what do they do to the heart? Do they increase its rate and contractility? Because they pretty much always go together, or do they not? And so you can see on the left, right on the axis, you've got phenylephrine, vasopressin. They're pure alpha. Metaraminol would be there as well. Pure alpha. They just vasoconstrict. They do nothing for the heart. NORAD, little bit in the middle, does a bit of both. Epinephrine, adrenaline, if you give a lot, does lots of both. Ignore the dopamine. Low dose adrenaline does probably more for your heart rate than it does as a vasoconstrictor. And then dobutamine vasodilates you a bit, but gives you good central inotropy and chronotropy. Milrinone vasodilates you even more, primarily, like we say, in the lungs, and gives you positive inotropy and chronotropy. So I find that diagram quite useful when I'm trying to work out what do I need to do to the patient, right? If they got a heart problem, or is it a peripheral problem where they're vasodilated because they're septic, or they've had anaphylaxis, or they've got spinal shock, or is it a central problem because they've got myocarditis and cardiogenic shock? And you can choose on here kind of where you want to be, and then you can choose the drug that's closest to where you want to be. So that's kind of useful. But actually, I think you can probably simplify this even more. And this is how I actually think about this. This is, again, same website. This is from Critical Care Clinical Guide by Hollenberg, who has this really nice axis that he draws for these. And I just essentially use this. So right at one end, phenylephrine, NORAD, dobutamine, epinephrine, adrenaline, dopamine, adrenaline, dobutamine, ignore the dopex, isoprenaline. And so what he's essentially saying is, at one end, you've got things that will drop your blood pressure but increase your contractility and your heart rate. And at the other end, you've got things that will do loads for your blood pressure that by doing that will probably impair your cardiac output a little bit. Phenylephrine, metaraminol, prime examples, can make your blood pressure really good, but because your heart's pumping against a bigger resistance without any benefit of the drug, your cardiac output by maths will go down. So you can choose where you want to be in this axis, but there is no free lunch. So you have to decide what you want to do and what you're willing to sacrifice and what you want to get out of your vasopressors. And then you choose where you want to be on the axis, and then it tells you what drug you want. And if we modify this to put on the kind of UK things that we use, we'd ignore the dopamine and Dopex, we don't use that. We'd add metaraminol under our phenylephrine, and we'd put vasopressin way down that end in the alpha box because it's pure peripheral. It does nothing for your cardiac output whatsoever. And right at the other end, we'd add milrinone, which is doing loads for your heart and cardiac output, but actually vasodilating you all over the place. And that axis at 3 o'clock in the morning is how I think about vasopressors. I just think about, what is the problem that I'm trying to fix? Is it peripheral? Is it central? Or is it a bit of both? And then you can choose on that axis where you want to be. And if you look at that axis, you can see down the bottom, this effect on cardiac output pretty much crosses the 0 level with NORAD. And that is why when someone comes into ITU and they're shocked and you don't know why, and you just don't need something to fix the blood pressure, everybody defaults to NORAD because it has an effect on the blood pressure and is essentially cardiac output neutral. So that little bit of central action that it has is just enough to offset the fact that it's squeezing the blood vessels down. So it squeezes you peripherally. Your heart has to pump against a bigger resistance, but the NORAD gives it just a little bit of benefit, then they all balance each other out and everybody's happy. And that's why these kind of big studies that you see in sepsis or in cardiogenic shock, where they just use one vasopressor for 20,000 patients, they're all done with NORAD because it's just in the right place for most people, most of the time, for most things that drop your blood pressure. The further you get from NORAD, the more likely you are to need to be doing something really specific to warrant being there. If you're putting vasopressin up, if you're putting milrinone up, if you're putting isoprenaline up, you're probably doing something very specific because you're very far from the default vasopressor. The other thing that you'll see there is the middle three, NORAD, epinephrine, so adrenaline, and dobutamine, sit next to each other and cover that kind of middle ground. And that's also why, if you're only going to give one, see cardiac arrest, we choose adrenaline. It's why, say, on air ambulances and pre-hospitally, we often use adrenaline drips rather than NORAD and dobutamine, because we want one thing that we can squirt through a cannula. It's easy, it's simple. We probably haven't even got a pump. We're just twiddling the roller clamp on a drip bag to go a little bit faster, a little bit slower. And we just want something that's easy. And we can use adrenaline because it's in the middle. And actually, there are some studies from the early 2000s that compared just adrenaline with running dobutamine and NORAD and kind of balancing, do I want central, do I want peripheral, and tinkering very precisely, or just saying, you know what, let's just put everyone on adrenaline as their only vasopressor. And actually, you can probably do that for 48 hours without any difference in patient outcomes. The longer they need a vasopressor, the more benefit you get from having the independent control of peripheral blood pressure, peripheral resistance with your NORAD versus heart rate and contractility with your dobutamine. But if they're only going to be on a vasopressor for a little while, it's probably just fine to run them on adrenaline and just be done with it. And that's, again, like I say, what we do in all the pre-hospital environments because it's easy. So the reason for those being the ones that we use commonly is because of this axis and because they sit in the nice middle ground where they benefit your blood pressure, but they either benefit your cardiac output a little bit or enough to offset the extra resistance that they're putting on in the periphery. So that's the 3 o'clock in the morning. How do I choose a vasopressor slide? And if you just, have that on your phone, that pretty much tells you when cardiology are telling you at 3 o'clock in the morning to do something really strange. One, it should tell you why they're doing it. And also probably more significantly for most of the people in the audience here, it allows you to detect when someone's doing something really stupid. And it sort of enables you to go, are you sure you want to be running, 20 mils an hour of NORAD and nothing else? Or are you sure you want to be running, the third syringe of metaraminol and adding vasopressin and nothing else? Because if you think about them on the axis, you can start to detect people doing really unusual things. Now, sometimes you've got a really good reason, but it should certainly prompt you to say, oh, dobutamine and milrinone, that's an interesting combination. Why could you explain why you're using those two together? Because kind of do the same thing. And so that should enable you to detect unusualness and then to understand, hopefully, people's rationale for what they're doing. That is all the slides I have. So that's back to Di, I think.
Yeah, great stuff. Thank you very much. We have got one question for the same question for all speakers in the chat box, and that is for each speaker, if we could take, what's our take-home message? If we could take one thing from each of the presentations, what would it be? Hannah? Sorry, I'm putting you on the spot.
Sorry. I think for mine, it's just, I just want everyone to be reassured that you're not meant to know everything. You're not meant to know every single rhythm that you're seeing on your monitor. But the most important things are you need to assess your patient. And just like, if there's some P waves, it's an atrial rhythm. If you can't see P waves, it's ventricular. And then just really get to know your lethal rhythms, like your BF, VT, and asystole, and then the rest you can figure out as you go along and from experience.
Okay,
yeah.
That's great. Thank you. Christopher?
Well, as an educator, I'm just always looking for stuff to steal. So I'm going to be having some of those
slide, aren't you?
Those cardiology slides. Probably the most user-friendly description of Torsade du Point I've ever heard. So yeah. I'll be parroting that straight back. And yeah, love the stuff about treating the patients at 3 o'clock in the morning. Those particularly those diagrams. It's lovely to have a simple diagram very early hours of the morning, and it makes the stuff easier to explain to people as well, having a nice picture. So yeah, thank you both for those.
Thank you. Andy?
Yeah, unsurprisingly, I think mine would be that last slide. I think my sort of approach to vasopressors is, if someone's giving me an explanation of why they're doing something with a vasopressor that does not fit on that simple slide, I tend to think they're probably trying to pull a fast one and, baffle you with science, and that does happen. And if you can't make it fit on that slide, I'm kind of not interested at that point. Okay. So yeah, if you can carry that on your phone and just give it to people and be like, okay, on this level, explain it to me. That works for me.
Yeah, that's not bad advice, is it really? So there are a couple of questions in the chat. One is, why is isoprenaline used in 3rd-degree heart block? I don't know.
That is a really either a very straightforward question or a slightly complicated question. The straightforward question is, or the logic behind using it, I guess, is that it is probably the most increase your heart rate vasopressor that we have. And so if someone's in 3rd-degree heart block and you really want to increase their heart rate, the one that is most specific for doing just that is isoprenaline. I have to say it's not fantastically effective, and the evidence would suggest that actually you're better off running low dose adrenaline sometimes. Depends on why you're in heart block. So yeah, and then once you get into the why you're in heart block question, then all bets are off, because then your vasopressor choice is way more complicated. But yeah, the logic behind it is that it's the most selective one for rate. And so if you're trying to fix a rate problem, go right to that end of the spectrum.
Okay. Next one in the chat then is, why is vasopressin the preferred inotrope in organ donation patients?
I guess that's for me as well. There's some weak evidence that it preserves core organ perfusion. So one of the things I didn't point out with the difference between vasopressin and like metaraminol, phenylephrine, NORAD is that there is some mechanism by which vasopressin, particularly actually at low dose, will actually improve particularly splenic and liver perfusion. And that liver, particularly when we're trying to do organ harvest, is one of the organs that we're often going for. So, so by using vasopressin rather than NORAD, in theory, you might get slightly better organ perfusion for the same blood pressure. Again, I think the evidence would suggest that that effect is so small that it probably doesn't make any clinical difference, but the harvest teams will go, you know, if you're going to use one or the other, you might as well use one that's theoretically better. Whether that makes any practical difference to the quality of organs, I don't think it. I mean, I'm not a harvest anaesthetist, so I don't know, but I don't think there's any evidence that it does.
Okay. Christina, does that answer your questions? Cool, thank you. Another one there on the cardiac monitoring, normally it comes up above the heart rate, something like sinus rhythm, atrial fibrillation, etc. But every now and again it'll say SVR. Is this systemic vascular resistance, or does it stand for something else? As I've seen this a few times and nobody on the unit has been able to say what it means. I think that might be for you, Christopher.
The only time on the heart monitor itself.
It's from Kaylee.
Yeah, if it's on a cardiac output monitor, it will always be systemic vascular resistance. Sometimes they'll be slightly confused by the fact that if it's been calibrated, they'll sometimes put another letter after. If it's been indexed, you'll see an I. Particularly cardiac output can be confusing for some people, because if it's indexed, if it's adjusted to the size of the patient and you've got a full set of data about the patient's hemoglobin, age, gender, etc., it will just say CI, and that's sometimes the case with systemic vascular resistance. It'll be SVRI, but SVR, as far as I know, always stands for systemic vascular resistance on a cardiac output monitor.
Okay, thank you very much. So any other questions, anyone? We have loads of people out there. We've actually got 42 attendees. It's brilliant. Thank you very much. On behalf of everybody, I'd like to say huge thank you to Hannah and Christopher and Andy. Really interesting. I've learned loads this evening. Thank you very much. Thanks for your time and everything else. Liz, I'm going to hand over to you to do something about prize draw.
Yeah, so bear with me. I'm just going to share a screen. So basically, Abby's been keeping a note of everybody that's attended, and I've got actually a list. It's on my phone, so I can't pick it up. But you've all been allocated a number as you got registered. So I've got a random number generator when I can find it on here. And what we're going to do is do a random number generator, and then if that person's here, you have won a voucher, which we will get sent electronically to you. So let me just match up on my phone. Catherine Bartlett, if you want to unmute and just so that we know that and
Kate
confirm.
Bartlett, I saw her on the list.
Yeah.
Where are you, Kate? Are you all right? I haven't seen you for ages. You're on mute.
It wouldn't work. Yeah, no, I'm still here.
That's fine.
Thank
We'll email something over to you.
Thank you.
Liz, can I just jump in a second?
Yeah.
Catherine, I've not got your email address on my list. Would you be able to just pop it in the chat, then we can get
Yeah,
the prize here?
I've been paying attention.
Brilliant.
There's lots of messages coming up on the chat. The inotrope diagrams were great. Thank you very much for that. Thank you very much. Very informative. There was another one just before that that says, thank you. All three presentations really helpful and interesting. Really interesting. Very helpful. Access to the slides would be amazing. If all three speakers are happy to share slides, then we can make them available for those of you that are here. Very interesting. Thank you. All definitely need more education like this. I would agree with that completely. Great sessions. Thank you. Thank you so much. This has been brilliant. Have learned a lot. Very interesting. Andy's just put the link on the chat for the inotrope slide if anyone wants to copy that. If not, we'll put it in on the or if you haven't got a chance to do it, we'll put it in with the slides when we circulate them.
That
Fabulous
website,
Sorry?
just to note, that website's got tons of other critical care stuff on. So if you sort of click back a layer, you'll get, they've got an entire critical care like pharmacology textbook online, basically. So it's got all the drugs, index, doses, how to make them up, everything. It is Australian, but their practice is very similar. So it's all very relevant.
Excellent. Thank you very much. Just remains to say thank you, for me to say thanks to all of the committee, because we've all worked on, everybody's worked really hard behind the scenes this evening. And I think it's fair to say our first Zoom study evening was okay. So we look forward to seeing everybody in person at some point, maybe not this year, but early part of next year at the source. And hopefully we'll be able to do something similar to this before Christmas one evening. Hannah, we wish you all the best in your new ventures. Good luck with
Thank you.
life in America.
Thanks.
Anyone, any other questions, queries?
I'll just say, what I'll do is, to everybody's email address that I've got, I'll send an evaluation form. When you return it, I'll send you your certificate online. I aim to get the presentations, when they get sent to me, I'll email them out to people rather than putting them on the BACCM site. But the actual recording for this evening will go on the BACCM site, and I think from what I can gather, it will actually go on the Yorks and Links page. But I will sort of confirm that in an email to everybody when I send the certificates out. I'm just not sure. I know I've got to stop recording, and then I've got to suss out how to transfer.
I have to tell you, and Andy will kind of realise that I'm telling the truth, but Liz is our IT expert because I certainly am not. But anyway, so thank you everybody for your attendance and your interest, and we look forward to seeing you soon. Good evening, good night. Thank you.
Can our committee members just stay online? Because I just want to run something by you.